All right, guys, moving on to the next chapter, 26, head and spine injuries. So this is all the fun stuff like concussions and spinal cord injuries and brain bleeds. So the central nervous system includes the brain and spinal cord. Hopefully you guys all know that. Um, Now, you don't need to know necessarily this for the National Registry. I don't think they're going to have like a picture and have you label it, but this is just so you guys are aware of what's what for some of this vocab. When we talk about the cerebellum or the spinal cord or the um, brainstem, those kind of things. So cerebrum is probably the majority of the brain. It does 75% of the brain's volume. Two hemispheres, four lobes, but yeah, I don't think you guys really need to know anything about the lobes. Just be aware that that's how it's organized. Two hemispheres, four lobes. And the cerebrum does most voluntary motor functions, conscious thought, your personality, things like that. Cerebellum does movement, and the brainstem does all the automatic stuff. So I would just be familiar with that. Cerebrum does all that kind of the voluntary stuff, personality. Cerebellum is movement. Brainstem is the automatic stuff like breathing. So just be familiar with those three things. Spinal cord is kind of the information superhighway that travels from the brain out to the body. And the brain and spinal cord has these awesome protective layering called the meninges. And I think we've already talked about that when we talked about the medical issue of meningitis. So just know these three layers, just know that they exist. The dura mater is the tough, fibrous outer layer. And there's two inner layers, the arachnoid mater and the pia mater. So there you go. There's what it looks like. Once again, I don't think on the National Registry there's going to be a question, a labeling exercise or anything, but that's just what it looks like. All right, cerebral spinal fluid, that is all the awesome fluid that's inside the brain. It is not blood, it is completely different. It's only about 125 to 150 milliliters of CSF. It acts like a shock absorber, kind of protects the brain, and it is moved around though by the brain ventricle. 31 spinal nerves, just understand that's how it works. Our brain sends impulses through the spine, and then the spine's kind of the intermediary, and then it sends it out. So that's what that looks like. And dermatomes. Dermatomes are related to it. It's basically just shows you here what part of the spine controls what part of the body. All right, cranial nerves. These initially seem complicated, but they're not. It's just saying there's 12 nerves in our brain, and they control stuff like sight, smell, taste, hearing, facial expressions. So it's a crazy, scary slide. I know it's super, super, super busy, but I liked it because it does have all the stuff on there. However, I'm going to send you guys a link to a website that explains it not so chaotically. So just be aware that there's 12 cranial nerves. All right. Know this, the sensory nerves and motor nerves, and there's actually different names for them too. So just understand sensory nerves, it's sensory information, right? So it is from the body to the brain. So sensations, so temperature, pain, those kind of things. Motor nerves are the opposite. It goes from the brain out to the extremities. So know what a sensory nerve is, know what a motor nerve is. The other way that we can name these is afferent and efferent. So no sensory and motor, and also no afferent and efferent. Okay, of course, medicine, we like to have different names. Afferent is, it depends on how you can just straight up memorize it, or the way that I try to remember it is afferent is arising, as in it's moving towards something, where efferent is exiting and going away from something, right? So sensory nerves, they arise the information, it comes to the brain. Efferent nerves are exiting the brain and going out to the extremities. So just be familiar with those vocabs. Connecting nerves, just saying that that's how it works. It goes to the spine. Spine does a lot of transfer of information up to the brain. All right. The other thing you should know, just for purposes of the test, you may not get a question directly about some of these, but they could be included inside the question. So you have to kind of prepare for that. The autonomic nervous system, you can try to memorize that as just automatic nervous system, divided in two parts, sympathetic and parasympathetic. Sympathetic is your fight or flight. Parasympathetic is your rest and digest, kind of the opposite. So just know that. Autonomic has two branches, sympathetic. This is another crazy slide. You don't need to memorize all this stuff, but this is just the breakdown of the nervous system in its entirety. And you can see there, the central nervous system is up top, peripheral nervous system's down there, and you can see it goes afferent, efferent, all that kind of stuff. But you won't need to know this necessarily. It's just to kind of show you the breakdown. All right, skull. Talk about some of these brain injuries. So the cranium, 80% brain tissue, 10% blood supply, 10% CSF. So with those numbers, though, what that means is if I have all of a sudden I have 15% blood because I have a bleed somewhere, well, that 5% has to get taken out somewhere else, right? So those are our numbers. I don't think it'll be on the test or anything, but just understand that those are the hard numbers. So if any of that stuff starts to change, then well, we don't have a lot of room to play around there. So for example, I worked on a patient in a hospital who had been shot in the head, and he had this massive amount of bleeding inside his head, and he ended up losing brain tissue because the swelling, the pressure had to go somewhere, and he actually was losing brain tissue out through his forehead. Surprisingly, he made almost a full recovery. At least when I left, he was actually walking around, so that's pretty amazing. All right, closed injuries, easy day, right? Just one's not open to the environment, one is. So head injuries can very commonly happen for, assault, old people falling, sport-related injuries, all that stuff. In fact, there was a woman yesterday in a hospital who was apparently being aggressive. She had coronavirus and she was ignoring social distancing rules and she was going kind of nuts. And someone, I don't think it was a nurse, it didn't say, it just said she was shoved and she was 83. She fell over, hit her head, and died. So elderly people falling is actually a pretty scary deal. You can pause this if you want. I'm not going to go through all of these, but these are the signs and symptoms that we're looking for the head injuries, okay? So now that irregular breathing pattern, widening pulse pressure, slow heart rate, this actually a triad, and we'll talk about that in a little bit. So you can pause this, look at some of those signs and symptoms, just be familiar with those. All right, scalp lacerations, they can be minor or serious. Even small lacerations can actually lead to a lot of blood loss. Our head is a very vascular area, right? Lots of good blood supply. So if you have a cut there, that means there will be a lot of bleeding. So you have to be careful. All right, skull fracture. We were going to talk about all the different types of skull fractures. Pay attention to these two things. I'd write these down, raccoon eyes and battle signs. So raccoon eyes is basically double black eyes. And luckily the name helps us out. Looks like a raccoon with black eyes, right? Now, battle signs is bruising that develops behind the ears, but specifically the mastoid process. And that is actually indicative of a certain type of structure. And we'll talk about it. So there you go. You got raccoon eyes on the left, you got battle signs on the right. So now we'll get into the different types of skull fractures. Linear skull fracture is about 80% of skull fractures. It's the most common one. Does usually need x-ray though, because it's not like there's a bone sticking out or anything. So you really can't tell by looking at it. So for any sort of head injury issue, I would take to the hospital to rule out any sort of fracture. All right, compressed skull fracture. So that is, you're gonna see it. You can actually tell that the bone, something has happened to the bone structure itself. Basilar skull fracture, that is going to be, so that's kind of on the bottom of the skull, and that is the one that specifically has raccoon eyes and battle signs. Okay, so be aware of that. You can have raccoon eyes and battle signs from different fractures and different bleeds, but definitely know that a basilar skull fracture equals raccoon eyes and battle signs. Okay, so now traumatic brain injuries. You have your primary brain injury and then your secondary brain injury. So think of the primary brain injury is, for example, that guy who was shot in the head. So primary brain injury is that bullet in the brain. Secondary brain injury is going to be the after effects of that. 2, 3, 4 a week, 2, 3, 4 days later, a week later, whatever. Once that intracranial pressure starts to swell, or if it damaged some part of the brain, that's the kind of secondary stuff that you're going to see a little bit later. And examples of these secondary injuries that might happen down the road are going to be hypoxia, hypotension, cerebral edema, which just means swelling, intracranial pressure or intracranial hemorrhage, and also increased intracranial pressure. Cerebral ischemia just means the brain isn't getting enough oxygen, and infection. So coup, counter coup, just write this down, just know what it is, which is that, for example, like a windshield is a common example, where the brain is floating around inside our skull. And if there's a sudden movement forward and then a sudden movement back, like a whiplash injury, the brain is also bouncing around in there. So you can have an injury to the front of the brain and the rear of the brain. So just be familiar with that. The term, the vocab term is coup, counter coup, which means kind of two different brain injuries. All right, ICP, we don't talk about it a ton in this class, but it is very important to keep an eye on. In fact, any sort of head injuries that I've worked with, like in the ICU setting, they actually have ICP monitors. They actually put a little probe inside the brain, and they actually measure that pressure. The typical ICP should be about 15 millimeters of mercury, which isn't much. So that means a little bit of swelling can actually cause a lot of damage. And it's because that brain can expand. And in fact, I've seen some patients where their ICP is so bad, they actually remove a portion of the skull. So that way the swelling can kind of come and go and do its thing. And weirdly enough, they actually take the piece of skull out, little plate of skull, and they actually bury it in the abdomen somewhere so the bone survives and still gets blood flow. And then later, once the patient's recovering, then they'll try and put that bone back in. So once again, you don't need to know all these, memorize all these, but look it over, just kind of know what we're talking about for mild versus moderate or severe. And you can see, if you can read it, you can go down, you can see where mild says pupils are still reactive, and then whereas severe, they're not reactive at all. Or their blown pupil, sometimes we call it, is a dilated pupil, which just means it's really big. All right, so intracranial hemorrhage is going to be bleeding that's in there inside the cranium, and that will definitely increase ICP, because remember, we don't have a lot of room to expand there. So even a little bit of bleeding can cause a lot of damage. So there's different types of bleeds, and we'll go through them. But before we get there, we want to talk about Cushing's triad. I would write this down. The EMT level doesn't have you memorize a lot of these triads and certain things, but Cushing's triad is one of them. So these are, some doctors came up with this. They noticed for a lot of head injuries, these were specifically ICP, these three things were happening consistently. So elevated blood pressure, decreased heart rate, and irregular respirations. And that can be Cheyne-Stokes or Biots or anything like that. But really, it's just irregular. Just their breathing pattern is messed up. And there's a little picture of it. And then I know it's kind of a cartoonist slide, but on that bottom right, it says it should not be confused with Cushing syndrome. And that is true. Some people do get that confused. Cushing syndrome is an endocrine disorder. It's totally different. So there's a triad and there's a syndrome. All right, so things that can increase intracranial pressure, these are the things like the types of brain injuries, right? So an epidural hematoma is between the skull and the dura mater. So I would write these down just so you're familiar with an epidural versus a subdural, okay? So between the skull and the dura mater. Subdural hematoma is an accumulation of blood beneath the dura mater, but outside the brain. So I know we're talking about a few millimeters of difference here, but it can actually make a pretty big difference in patient outcome. So we're going to nerd out a little bit on the epidural versus subdural. Epidural hematomas are usually caused by bleeding of the middle meningeal artery, where subdural hematomas are due to bridging veins that help circulate blood. So epidural hematomas, the blood is limited in its spread because it is kind of confined to that tight space, and it really can't bleed a ton because everything's kind of holding it in there. Whereas a subdural hematoma is actually more deadly because there's more room for it to bleed, and that means there's more room for intracranial pressure to rise. Now, intracerebral hematoma is bleeding within the brain tissue itself. And one of the normal common cause of that would be something called a Berry aneurysm, where it's just a weakness in some of the walls of the blood vessels. It's just like really thin and weak, and then a perfect storm of stuff happens. Boom, that weakened layer ruptures, and now you have an intracerebral hematoma. And you can also have a subarachnoid hemorrhage. And so those are important, but I think for the test, it's going to be that the subdural versus epidural. Those are the big distinguishing thing you need to learn there is epidural versus subdural. All right, concussion. You've probably heard of this before. I mean, there's movies about it now. It's kind of all over the news. Luckily, the like school organizations and sport organizations, they're finally taking this stuff seriously. They didn't for a long time. And part of that though is that we just didn't know how bad it was. We always knew if someone got hit in the head and passed out unconscious for a while, yeah, that's pretty bad. But there was some people were thinking like, oh, well, he didn't pass out or anything, so he's up, moving around, he's talking, he's probably okay. Well, that's actually not that true, it turns out. They even said about 90% of patients do not experience a loss of consciousness. So just because a patient is up, moving around, doesn't really mean you can't really tell how bad off they are. And as a reminder, I had a friend of mine who was a paramedic. There was a head injury patient, but head injury patient was up, moving around. He was passing all the tests. Everything was good. And later that day, the patient returned to the ER. So he had refused transport in the morning because I feel fine. He's up, moving around, he's talking, everything seems fine. So my paramedic buddy did some tests, everything checked out. He had him sign a refusal form, and that was it. Well, hours later, he went to the ER with a skull fracture. So just because your patient is up, moving around and seems okay, doesn't really mean anything. Now, a patient with concussion may be confused or have amnesia, and a concussion lasts a short time, the initial effects of that, but the long-term effects can even last a few weeks, depending on the nature of the concussion. They're going to be dizzy, they're going to be weak, visual changes, nausea, vomiting, ringing in the ears, slurred speech, inability to focus, lack of coordination, and some motor function problems, inappropriate emotional responses, headaches, disorientation, that kind of stuff. So just general confusion. In the military or other places, they call it, oh man, he got his bell rung, which is that's it. It's that initial impact, and people are going to be kind of confused and have a headache, and they're going to be kind of out of it. So that's a good indication that something is wrong. All right, a contusion, that involves physical injury to the brain tissue itself. And this one can have some pretty long-lasting permanent damage. So just be familiar with that. Contusion is like brain bruising, where concussion is kind of just like a minor shock to the system. Now, brain injuries can result from blood clots, or hemorrhages. We know that to be a stroke. In that critical care paramedic class I'm taking, they actually break strokes down to like 5 different types of strokes. So I know we talk about ischemic versus hemorrhagic, and that's true, but you can actually break it down a little bit deeper if you want to. You could have some of the same signs and symptoms, but obviously you wouldn't have that history of some sort of head injury, trauma, impact. So that's your brain stuff, okay? So just know epidural versus subdural, and a concussion and those kind of things. Spine. Similar to the brain, the spine is sensitive. It has a certain range of motion, and it does not want to extend past that. So if a person falls or rotates or anything like that, you are now stretching the spinal cord past its range of motion, and that can cause a lot of issues. One thing's called neuropraxia, and it's a stretching of the neurons, and initially that might present not too badly, but as time goes on, a person can have some numbness and weakness that goes along with it. So we've already talked about this. Because we don't have X-ray vision, we don't know what's going on. If there's any sort of motor vehicle collision, pedestrian hit by a car, falls, blunt trauma, stuff like that, we just got to be careful that it could be some sort of spine injury. And same thing with these. Hangings, sure, they will have a spinal injury with that, but I don't think most people recover from hanging. So, however, diving injuries, I would just say as we're approaching summer, really out, if you're like, hanging out with friends in a lake or whatever, there's just no reason to dive, honestly. I know people who have had spinal injuries from diving, and I would just say be really careful. But if you are working as an EMT and you're called to a diving accident with neck pain or something, you really got to be careful about that spinal injury. We don't have X-ray vision, so we don't know what's going on. So that's when we're going to do full spinal precautions and the cervical collar and all that fun stuff. Head injuries. So Glasgow Coma score, right? We've been talking about this for 9 months. Hopefully you remember this, EVM 456, and you kind of grade your patient on what's going on. It gives you a number. So there it is. You can write it down if you want. I will probably throw another GCS question on the exam. But you guys will have the full Google machine at your disposal, so you can just Google this chart if you need to during the exam. All right, so for our head injury stuff, we just want to make sure we maintain an adequate airway, we control bleeding, CPR if we need to, and supportive care and evaluate them. This is a kind of a random one. There's always a question or two about this in the National Registry for some reason. It's going to be helmet. So guy, motorcyclist got some sort of accident. What do we do with that helmet? Well, we generally want to leave it on, unless of course there's some sort of breathing airway compromise. It gets in the way of treating, or you can't immobilize the spine or something like that. So generally leave it on except for these things. And part of that is the helmet is kind of suction cupped on the head there. So it actually takes a lot of force to remove that helmet. The last thing we want to do to this person's head and neck area is be applying a lot of force. So just be careful with that. The preferred method is a 2-person job. So that might be a question you'll see in the National Registry or something is generally we want the helmet removal to be done by 2 people because it is kind of a sensitive thing. Now there's an alternative method, which is right here. So you can kind of do it. It takes a little bit longer. But at our level, I'm not going to ask you questions about this, about specifically the alternate method or anything. I might ask you a question about in which situation would you leave the helmet on kind of thing. So that is our lecture on head and spinal injuries. I think I've highlighted the important bits. I will send out a chapter outline that kind of covers this lecture in like bullet format. And when we start doing video conference meetings, if you guys have any questions or anything about this, we can talk about it then. Thanks.